this is Dr. Apurv Mehra with Dr. Mathew Varghese, and we are going to play this series called as Out of the Books, where we would have a question answer session. The questions have been prepared by our teachers, and the teacher who's answering is not aware of what question is going to be asked. It's just like the Viva and the DNB and MS exams, and we will be discussing a few cases here. Let's start with one of the classical cases that you will always get if it is available in the wards. A child with cubitus varus. So, sir, the first question: how should a candidate of MS or DNB or diploma orthopedics appearing for the exam speak the diagnosis? What should be the language?
First of all, in any diagnosis that you make in a child, you have to have an anatomical diagnosis. And then you have an etiological diagnosis. So the anatomical diagnosis has to be there, and the etiological diagnosis has to be there. You may say one before the other, but by and large, the anatomical diagnosis comes first. So, if it is a cubitus varus, everybody knows. If it is a 6-year-old child, so they start off with a 6-year-old child, repeat that. We're not so worried about the age as the first part of the diagnosis.
Right.
But it becomes important in the discussion that follows.
Right.
So out of the familiarity with what students present, so I would have to say a 6-year-old child who's presented with a right-sided cubitus varus deformity in a right-hand dominant child. The moment you have an upper limb presentation, the side becomes important. Right hand or left hand dominant. So any problem? A left-sided cubitus varus in a right-hand dominant child is less disabling than the other way around. So in an upper limb, you always say which side is the dominant side. So a right-sided right-sided cubitus varus in a right-hand dominant child following a supracondylar fracture. With or without myositis, with or without neurovascular deficit. See? So if you have sometimes the supracondylar fracture is 1 year old, sometimes it is 10 years old, depending on the age of the presentation. So it's sometimes useful to say 6-month-old supracondylar fracture. Now here, have I given you the etiology? No. Completely a post-traumatic supracondylar fracture. Okay?
Right.
So
that comes to my fifth question, sir.
So that is a complete diagnosis would be a 6-year-old boy with right-hand dominant boy with a cubitus varus deformity with following supracondylar fracture, post-traumatic, suffered 1 year back, presenting to us with this deformity.
So that comes to my fifth question, sir.
Mm-hmm.
Why is it supracondylar fracture humerus? It also comes to the second question, sir. Why did I label it as cubitus varus?
Now, important thing which a lot of students make a mistake on. To call a cubitus varus as cubitus varus, there has to be full extension of the elbow. If you cannot extend the elbow fully, please do not call it a supracondylar cubitus varus.
Right, so you mean to say complete extension has to be there.
For cubitus varus diagnosis, complete extension has to be there.
So if there's a flexion deformity, I should not be speaking.
You
that.
cannot say whether it is varus or valgus. You can say, sir, there seems to be a degree of valgus or varus, but I cannot comment because I cannot extend the elbow fully.
Right.
You cannot say that. That's true for valgus also. So either valgus or varus is labeled as varus or valgus only when the elbow can be fully extended, not otherwise. To answer your question, why do I say supracondylar fracture? First of all, there is a history of significant trauma. Now, a lot of patients come to you with history of trauma. They may attribute the episode to trauma, but actually it may not be trauma. It may be some infection. It may be something else. So you have to be very clear. There is a history of significant trauma. When do you say it is significant? Their symptoms started immediately afterwards, number one. Number two, that incapacitated the limb. It needed an intervention in terms of a plaster or something else.
Right.
So it's significant trauma. So there's a history of the age of the child is the age when supracondylar fracture is common. Number one. Number two, there's a history of significant trauma. And number three, he had a cast immobilization following which there was healing and subsequently he has developed the deformity.
Right.
This is a non-progressive deformity. If it was a physeal injury, the deformity could have been progressive. It's a non-progressive deformity. That's history part. Until now it's history. Okay, but your crux of the diagnosis is on clinical examination. What is your clinical examination? One, the typical gun stock deformity that we see here. Why is it a gun stock deformity? When you have cubitus varus like that, the arm becomes the butt of the gun and the forearm becomes the barrel of the gun.
So it becomes like this.
It's like that. Typical gun stock deformity number one. On inspection, there is medial and lateral supracondylar ridges are thickened. The relationship of the three bony landmarks are intact. Supracondylar ridges on either side is thickened or roughened or irregular. The three bony landmark relationship is intact. Okay? Then there are three things that you have to look for specifically. When you have a supracondylar fracture, the common fracture where you have the distal fragment, how does it go? Where does it go? It goes into a medial displacement.
Right.
Distal fragment, medially displaced. It is posteriorly displaced. Okay, but it is tilted laterally. That's what gives you the cubitus varus. It's tilted laterally. It's a lateral angulation. Okay, it is tilted posteriorly. It's tilted posteriorly. Angulated anteriorly. So there is a tilt that has happened. Posterior tilt, but the tilt is causing the fracture site to be angulated anteriorly. But that a lot of students get confused with.
So medial tilt with lateral angulation, that's what you mean?
So the tilt and the angulation.
Right.
Medial tilt with lateral angulation. Posterior tilt with anterior angulation.
Right.
Okay, so you need to show where the apex of the angle is pointing.
Right.
Anterior. Where is the apex of the angle pointing?
So if I take this as the proximal fragment, and if this is the distal fragment, and if this is medial, this is lateral, this is the angulation,
Lateral.
and this is the tilt.
Tilt is medial.
Right?
Yeah.
And if this is the proximal fragment, and if this is the distal fragment, this is the posterior tilt with an anterior angulation.
Yes.
That's what you want to say?
That's what I want to say.
And this is the very clearly they should be speaking about.
In addition, there is a rotation that happens.
So medial rotation as well.
So it is rotated internally. So distal fragment is rotated internally. There is a clear consequence of each of these.
Right.
which is demonstrable physically on examination. So, once you say that the three bony landmarks are intact, lateral epicondyle, middle epicondyle, they are intact, you think it is above the elbow joint. If the elbow is affected, then the three bony landmark relationship with the abdomen. So that's your clue that it is above the elbow joint. Lateral and middle supracondylar ridges being roughened, that is clue that there is some, both sides there is a problem and there is some healing that has happened, periosteal reaction and new bone formation, and therefore there is something that is irregularity is a clue. Now the next comes to the movement. The lateral angulation that is there, that contributes to the varus, the tilt that is there, the middle tilt that is there. But the posterior tilt, what does it do? It throws the elbow backwards. Okay, so your extension is usually exaggerated. So there is cubitus recurvatum, or some people call it procurvatum. So cubitus recurvatum is there, and that is because of the tilt of the distal fragment posterior. Okay, now the medial tilt, the tilting in there, what does it do? It takes the whole elbow outwards. It is tilted in, so the whole elbow goes out. So the range of supination is exaggerated and the pronation is restricted. Okay, so in the tilt backwards causes recurvatum, but the flexion range is less. But in true sense, when you compare with the opposite side, the range of movement is the same on the two sides, unless there is some stiffness there. And usually supracondylar fracture, because it is above the capsule, there is no stiffness. Early on stiffness, later on, unless there is massage and myositis, then you will say there is stiffness.
But arc of movement is changed.
Arc is changed. Range is the same. Arc of movement is changed. Similarly, because of the tilt, the arc of supination pronation is changed, the range is the same.
Right.
That's clear? Yeah. Now, how does the rotation manifest? Now, rotation, when you check for this tilt, what happens? The rotation is in this plane, it is rotated internally. So, how do you check for it? It is above the joint, so there is nothing at the joint that you can check for rotation. So, because there is a humeral rotational malalignment, you look for has it caused a problem in the arc of movement of the shoulder. So, therefore, you check for the arm abducted and check for are the rotations internally of the arm exaggerated like that. That's exaggerated.
So you mean to say internal rotation
Of the shoulder is
is
exaggerated.
more.
It is apparent
Right.
because your reference is the forearm. Using the reference of the forearm, the arc of internal rotation is exaggerated, or external rotation is reduced.
So you mean to say this is Yamamoto sign?
Yamamoto sign, which was described way back in the 80s, is demonstration of
The same thing what
this,
you're speaking.
of the same thing, by a test where the person stands up with his hands leaning forward and then he does this.
This is an active test or a passive test?
It is a test where he's doing it actively, but you see the end result of that active movement.
Alright. So in Yamamoto test, we are seeing an exaggerated internal rotation of the shoulder, where the candidate or the patient will bend down forward, and you will see the back of the forearm, the dorsum of the forearm, and the gap between the back.
The gap between the dorsum of the hand and forearm and the back.
Back of the patient, right? So, and this is an increased internal rotation at the
I
shoulder
don't like
gap
to
length.
use that expression very often because all examiners do not know this name.
Right.
I never give negative marks to a student for not naming things.
So they should be able to
He should know
answer.
the principle. What is the principle? Principle is there is a deformity because of rotation of the distal fragment. The arc of movement of the shoulder as assessed by a reference of the forearm is increased in internal rotation, decreased in external rotation.
But a total range of movement is still same.
Total range of movement is symmetrical to the
So
other
that's
side.
right.
So these are the features, and this is a very important feature. Why? Because in a lateral condyle fracture, the medial condyle is intact, attached to the metaphysis and the diaphysis. So there is no rotational change there. In a lateral condyle fracture also, there is no rotational change. And because there is no rotational change, this sign would be clearly negative. The rotation of the shoulder in this position or the Yamamoto sign will be symmetrical on the two sides, and which will clearly tell the candidate this is not supracondylar, this is lateral condyle, this is medial condyle, or it is supracondylar. It's a very important differentiating point.
What are the other causes of cubital varus?
Cubitus varus can be because of a physeal growth arrest, and the physeal growth arrest may be post-infective, it can be post-traumatic.
Right.
Okay, so that's a possibility. It can be because of a surgical intervention that you've done. A surgery to the elbow for something, you put in wires or screws and you've contributed to a growth arrest. So growth arrest from any cause, whether it's infective, whether it is traumatic, whether it is whatever, can lead to a cubitus varus deformity where the outer growth is more, inner growth is less.
And sir, carrying angle, you already told the only thing the candidate should remember is doing
You look at
extension.
both sides. The carrying angle is standing with the arm fully extended and forearm supinated, palm outstretched, and then compare the two sides.
And the next question
Long
is,
axis of the arm, long axis of the forearm, measure the angle.
how do you manage such a case of cubital varus?
No. Cubitus varus, the usual cause is supracondylar fracture, and if the child, usually they come to you after 1 year or so. They may come in 3-4 months also, but by the time there is some stiffness, especially if they've had some traditional treatment done, massaging done, there is some myositis, there is some stiffness, you cannot make out cubitus varus. It is only when the elbow is completely straight, then they realize, oh my god, this is deformed even though the joint range of movement is good. It is a deformed elbow. So the first thing is they usually come after 6-7 months.
Right.
And after that, they say, okay, you want to operate right now? He's just recovered from an injury. He's just become mobile in the joint after physiotherapy and exercises, and you give him time to recover. Is there associated physeal injury in supracondylar fractures? Usually no, unless somebody has put some wires or something like that, and the wires have got infected, and there is some growth arrest because of those infection in the wire.
Right.
Okay, it's possible. They put in some middle wire, they put in some lateral wire, the middle wire got infected, middle growth arrest is there, and therefore there is a problem. But usually that is not the case. Growth arrest is not the case in supracondylar fractures. But if the parents say this is increasing with time, please wait. Don't do anything.
Right.
You will wait. If there is a history, so if the candidate says, okay, sir, the father is emphatic, I have seen him only today. The father is emphatic, the deformity seems to be increasing. I need to observe the child. I'll call him back after 5 months or 6 months, see his height. If his height is increasing and the deformity is not increasing, I know there is no association.
Right.
So I'll wait. In a suspected growth arrest, how long do you wait? Patterson was the first one who described this observation by doing an epidemiological community study on the physeal growth patterns. And he described that any growth insult to a physis will manifest in about maximum 2 years. So you need to observe any suspected growth arrest for 2 years. So by that count, if you suspect there is a growth arrest by the history, because you're seeing it on one point, so you can rely on the history.
Right.
So then you will wait, observe him periodically, and then take a call. Usually the answer will be no, history would be wrong, and you rely only on physical signs, and that's how you decide on intervention. Coming to the timing of the intervention. Lot of students say that, sir, I'll wait till skeletal maturity. No, you don't have to wait till skeletal maturity. It can be done earlier than that.
Right.
The child doesn't have to suffer the ridicule of his buddies who call him somebody with a twisted arm. Okay, so he can be normal. But remember, surgery is a cosmetic surgery. These children have no functional limitation. They do very well. It's only a cosmetic surgery. Long term, can it lead to tardial palsy? It is described. But tardial palsy is a feature of Cubitus valgus,
More common.
not Varus. Rarely described, but don't say that in the exam unless the examiner puts it in your mouth.
He wants you to speak.
He wants you to spell out, is it possible? Sir, very rarely it's possible. It's not, normally it's only Cubitus valgus that leads to tardial palsy. So the surgery is indicated only because it is a cosmetic deformity and parents wanted cosmetic correction of the deformity, especially in a girl child.
That was about Cubitus.